the things that affect our practice today are things like COVID. COVID-19 is an enormous threat to patients. Even if they feel well and they don't have COVID-19, they're threatened every day by having to go to a doctor's office, to go for blood tests, to go for x-rays, CAT scans, PET scans. So they're threatened by this and they don't know exactly what to do. We have known that our patients, oncology patients, hematology patients, are vulnerable. Why? Number one, they're mostly over 65. At least half of our patients are over 65. So that makes them vulnerable. Number two, they have comorbidities, not only their cancer, but many other comorbidities as well, diabetes, and they have hypertension, cardiac disease, the common ailments. And now they have chemotherapy or immunotherapy, which further changes their immune status and gives them increased vulnerability. But how high is that vulnerability? Just a little? Or is it really, really high? And so there were two abstracts this year. They are late-breaking abstracts. COVID was a late-breaking issue. One is LBA 110 by Warner, and the other is LBA 111 by Horn. Recommend that people who are looking at this communication get back to the ASCO meeting and look up those two late-breaking abstracts. These two are very important. The first one dealt with about 1,000 cases that were collected from cancer centers. And they looked at that to see what's the risk to patients. And the mortality rate of getting COVID was 10%. Remember, the mortality rate in general population is somewhere, we realize now, about 0.1%. So this means it's at least 100 times higher for patients on chemotherapy. And furthermore, a quarter of the patients were hospitalized. So 10% within that quarter died. That puts this at a very high risk. And it means that I need to think about how to change my practice. In LBA 111, which is by Horn, this came out of Vanderbilt, they looked at 295 patients. And in my notes that I have from them, they have 73% hospitalization. So this is a huge risk to patients. What it means for me is, when I see my patients, I have to consider, do I want them to come back for extra blood tests? Do they want to have them come back for extra radiology procedures? Clearly, if I need that to make therapeutic decisions for the patient, I need to go ahead with that. And ASCO has guidelines. If patients need therapy, they should get the therapy. But it also means when they're not in for therapy, when they're not in for their chemotherapy, when they're not in for their testing, I have to minimize that risk of exposure. So what do? The first thing I recommend to my colleagues is do telephone consults, telephone follow-ups, do video consults with your patients so you can actually see how they look, and don't have them come back for an extra visit. Make certain that you've ordered just as few radiology procedures as you need to make decisions, and make certain that you have as few blood tests as needed. And make certain the rest of the time they're at home, masks, shields if they need to, but usually not at home. Make certain they wash their hands. We do that at the office, but they have to do that at home as well. And just as important as it is for everyone, it's extra specially important because of these two abstracts for our patients. And we now know what that risk is. Anywhere between 1/4 and 3/4 having to go in the hospital with a hospital-related shortness of breath, fever, et cetera. Now at City of Hope, we have a very active program where we have policies in place that say if you need therapy, you are going to get it, and you're going to get it in a safe environment. Patients and oncologists need to know that they have provided safe environments for their patients, or they can refer to a center, comprehensive cancer center, that has put those various different protections in place. And it goes beyond just masks and face shields and gloves. It really goes to how do you make certain that your patients are healthy and that they don't have COVID? How do you test them, make certain if they're going to come into the environment where they're going to be tested, where they're going to be treated, they in fact are COVID-free? And we have a very active testing program. We have a very active intervention program where if they've got something, they are appropriately advised who can delay their therapy for 1 to 2 weeks while they work out their risk and get rid of the COVID, and who gets their therapy right away with appropriate protections and face shields, et cetera. And these things are very important. So if a person listening to this has a hospital and they do not have a very active COVID program in place to test and to protect, they need to talk with their hospital administrators to put one in place. And we have at each of our hospitals in the communities, we help to lead those hospitals by having active COVID control plans in place. And most of all, when you are dealing with referring patients for surgery, make certain you refer to a comprehensive cancer center where you have all of the safeguards in place so you can get your surgery, you can get your radiation, you can get your chemotherapy in a safe environment. Nothing has to be delayed unless it's totally elective. And so this is an important message for each and every practitioner. Those are two important abstracts. So I'm pleased that those came out and give us evidence that we can take back to make decisions every day today.